cloud. So let's start with just a couple of stations first then, okay? So for the recording bit, I'll say that we are doing it because we want to talk about the strategy afterwards. Maybe other people are able to join who had registered. So let me share this screen. Am I sharing? Here we go. And then another one is this timer as well. Okay. I shared the wrong screen. Are you able to see something, everyone?
Yes, there is a one task is coming, Dr. Sam.
Okay. So
Sharing. You are sharing one station.
okay.
A stimulated task, yes.
So I would like you, if you are still happy.
Yes, it is clear, doctor.
Okay, sure. Yeah.
Okay, give it a read, and then we should start talking. Let me listen to this message.
Hello, I'm Dr. Annie, one of the doctors here in the gynae clinic. May I confirm your name and age, please?
Hi, doctor. I'm Helen Scott, and I'm 35.
How would you like me to address you as?
Helen is fine, doctor.
You can call me Annie. So, Helen, can you tell me what brings you to the clinic today?
Doctor, I don't know. My friend recently died of ovarian cancer, and I just spoke to my GP. I did a lot of search on that, and I just wanted to see if you can, if you can remove my ovaries. I'm really scared.
I'm really sorry about your loss, Helen. How are you coping with it?
I don't know. I'm trying to, doctor.
Mm-hmm. Would you like me to arrange some counselor at the end of the session?
Do you think that can help?
Yes, I know it must be a very difficult time for you, and in such moments, if you speak with somebody like a counselor, that might really help you to help you cope up in the situation. Is that okay?
Thanks. Yeah, thanks. Thank you so much. I will like that.
All right. So Helen, I can understand your concern regarding your friend, and I can understand that you also want both your ovaries to be removed. But is it all right if I ask you a couple of questions to know more about you, and then we can discuss the options after that? Is that all right?
Thank you, doctor. Yes, sure.
So Helen, tell me about your main worry. What makes you think so? Like apart from your friend suffering from this?
Yes, doctor, that she never had any. I didn't know that she had any problems. So suddenly she died, and then her family said that she suddenly got diagnosed with cancer ovary. So I just went to online and did some search, and it was all full of that ovaries can really suddenly become cancerous, and it's such a tragedy. So I don't know, I got scared and no other reason.
Helen, so basically, I would like to reassure you that every patient is different, every person is different. I don't know at the moment what the background must be of your friend, and I'm not sure, like, were there any risk factors, like any family history or any other factors that could have led her to have this have this cancer. But we as a team, we are here to help and support you in the best possible way. Is that all right?
Thanks, doctor.
So can you tell me more about your periods?
They're fine, doctor.
Okay, and are they regular?
Yes,
And do you use any form of contraception?
I'm on pills, doctor.
Which pill are you taking? Is it the combined one or the
It's the
progesterone
combined
one?
ones. Yeah, combined
And
ones.
how long you've been taking that?
8 years, doctor, since the last birth of my little boy, Georgie.
Okay. All right. And how many children do you have?
3.
3. And how were they born?
Uh, they were uh, they were all cesareans, doctor, because the first one was upside
Mhm.
down, like, the
Okay.
bottoms down really. So
Mhm.
that's
And
why.
were there any complications in the surgery that the doctor told you?
No,
Any of
no,
these?
no,
Okay.
everything was smooth. Other than
And any other pregnancies apart from this?
no,
Okay. And do you have any medical history for which you go to the GP?
no,
And are you up to date with your smears?
I am all normal, no problem there.
Okay. And sorry for asking. Do you have any history of any sexually transmitted infections in the past?
No, never, doctor.
Okay. And any surgeries apart from this 3 cesareans?
No,
Any allergies?
no allergies, doctor.
Okay. Did you have any history of any like having clots in the legs or any breast cancers or any other cyst or any other problems
Never
in the
any
past?
problem. No, doctor. No,
Mhm. Okay. Any family history of any ovarian or any
no,
uh,
no.
womb
My
cancer
family is
or breast cancer?
Mhm.
Okay. All right. Do you smoke?
I don't.
Do you take any recreation drugs?
No,
And any street drugs for fun?
no.
Okay. May I know your weight to height ratio, Helen?
It's 24, doctor. My GP did that.
Okay, sure. All right. Thanks, Helen, for sharing all this information. So, from whatever you said, you're 35 years old, you've had 3 babies, 3 children in the past, and all were born by cesarean section. And you're here looking for removal of your ovaries because you were concerned because of you lost your friend. Is that right?
Yes, doctor. That's right.
And you're currently on oral contraceptive pills
That's
for the
right.
past year. Yeah, all
Yes.
right. Is there anything else, Helen, you would like to add?
No, nothing.
Okay, so Helen, there are a few things that I would like to discuss with you. So, firstly, is basically there are some risk involved in removal of the ovaries at this age. Like few of the risks are basically because you've had 3 sections prior, so there might be a lot of scar tissue which might be inside the tummy. So during the surgery, which will be done by a keyhole, there are the chances that there can be injury to the bowel, bladder, the surrounding structures, and sometimes it might be also like very difficult in doing the surgery, and we might not be able to complete the surgery. Okay.
Okay.
Uh, the other things I would like to discuss is that basically, when we remove ovaries at such a young age, there are some detrimental effects which can happen to the woman because ovaries are an essential part of our body, which releases hormones, which is known as estrogen, and that is very important for maintaining the bone health and for the health of our blood vessels, health of our skin, and also our mood. Are you with me so far, Helen?
Okay. Yes, doctor.
And there are some long-term risks associated in case we remove your ovaries, like you will be having menopausal symptoms. Have you heard of any of the menopausal symptoms, Helen?
Um, my mom said that she had lots of, something called hot flushes and all that. So
Yes.
heard from her.
So, Helen, basically, when we remove the ovaries, uh, because of the sudden cessation of the hormone in the body, there will be because of that, you will experience a menopausal symptoms like hot flushes, drying of uh, the vaginal area. There, you will be more prone for having fractures and like fractures of the bones, and this might affect your like your mood as well. Okay.
Okay.
So, so these are the risks which are involved with removal of the ovaries. Am I clear so far, Helen?
Yeah, okay.
Mhm.
Okay.
Mhm. And Helen, I know there's a lot of information I've given you right now. I will basically give you patient information leaflet about what are the like pros and cons of removal of the ovaries at this stage. But since from whatever you've told me so far, there hasn't been any risk factor that has come out from the history that you've given me so far, which might make you at high risk of having an ovarian cancer. Um, and since like because of that, I don't see there's any indication of removal of your both your ovaries. Is that okay?
Yeah, doctor, but if I'm scared, you would, if I wanted to go ahead still, you would do
Mhm.
that, won't you?
Would you like to have some blood tests done just to see if you are at high risk of having any genetic disorder, like genetic predisposition for having any ovarian cancer?
What are the blood tests, doctor?
So if you would allow us, then there are certain genes like the BRCA gene, which can basically uh, help us determine and give us a risk
Sure,
whether
okay,
you
doctor.
are at risk of having or not.
Okay, yeah, sure. Yeah.
Okay. And if you want, I can also arrange an ultrasound scan just to see if your ovaries are healthy and if there's any cyst or any other
Okay.
swelling. Is that okay?
Okay, yes. Now
Is
what?
there anything else you would like to discuss?
So what will we do from now would be my next question. But we've run out of time.
I can't. Yeah.
Yeah. So my next question would have been, what would we do from now? You would probably give me another appointment, would you?
Yes. So basically, I will tell her that I'll discuss with my consultant. I've given her the patient information leaflet. If she still wants to go ahead, we'll ask her. I mean, I'll ask her that I can arrange blood tests for her, some scans for her, and then discuss with my consultant in the next appointment when she comes back in the follow up.
Yeah. Okay. So right. So what kind of negotiation was going on here? Was this completely, mm, you know, uh, successful towards the end, or was it like a failed negotiation, or was it like a continuing negotiation? And how would you handle if, well, which one was it, depending on the three types that I said? So if this was, suppose, a successful negotiation, you convinced me, I'm happy, you're happy, okay? So this probably was not that one, yeah, Annie?
Probably a continuation one.
Continuation one, yeah? So continuation one, what you would have, if we had a little bit, tiny bit of like even 30 seconds, you would have offered me another appointment, okay? It's not a big miss. If you're continuing it, it gets disconnected. I don't think you get really penalized for that, because if you're performing very well, RCOG will, the examiner will probably think that you would probably be, you would have done it if you were, if you were. So anything, any you think you missed?
Yeah, I think the initial part, I didn't ask her if she had any other symptoms or anything because I was thinking about it later when I came down, like when I started discussing. Yeah, any other complaints that she has?
Uh, like what? Tell me.
Like I just asked her when was the last menstrual period and whether her periods are regular, but any other symptoms like lower tummy pain or any weight loss, like
Okay.
those complaints basically, which I realized later on.
Okay. And anything else other than that? Anything
Yeah, I
else?
think little more systematic because I just came to the room and I just joined your meeting.
No, absolutely. No, and to be honest, Annie, I personally feel that it's okay when you're not systematic, okay? Honestly. I mean, I know we hear a lot from everywhere that, you have to be in sequence and systematic and all that. To be honest, my personal feeling is that if you got that thing ticked, whether you got it ticked in the beginning or towards the mid or end, as long as you are able to do it, it gets counted. Okay, so systematic, yes, it can help you, isn't it? to probably think more, think better. Yeah. But as long as you've said things, you're not going to lose marks because of whether you were systematic or not systematic. Okay. Anything else comes to anyone else's mind that could have been added? Please.
Yes, Dr. Sam, can I tell something?
Okay, Salma.
Only that one I can say that she's taking COC, that it will protect her, risks of ovarian cancer. One things,
Yeah,
and
good.
another thing that if she has no family history for BRCA1 and BRCA2 or the breast cancer risks and any other risks, so that means there is a less chance. That means very less chance that she will get ovarian cancer. But if her mom has any faulty gene or any cancer, then it
It's a
will
good
be
one.
4 to 5 percentage. Yeah.
Good. Anything else?
And BRCA1 and BRCA2, we can tell that if she has BRCA1, that any history of BRCA1, then the risk is 60 to 90%. If it is BRCA2, then it is.
But she did not give any such history, isn't it?
Yeah. Just to.
So Salma actually
donate.
pointed out both the points which I had here in my feedback. So that's very good.
Thank
Salma, you are doing good. Okay. Anyone else wants to say anything else at all?
So, Dr. Sam, we will not tell her we will run for you some investigation because she is young, less than 35 years of age. About her, and we did not ask about the
What
vaccination.
investigations are you asking about?
Because for me, she is less than 35 years of age. We have to tell her for her satisfaction, for her concern, that we have to do LDH, alpha fetoprotein, beta serum HCG. These are the four.
Why are you doing those? Why are you doing? What's the indication?
I'm not saying indication. I'm asking her for her satisfaction. Because she has so much concern. So we will tell her that you are less than 35 years of age. We will run some investigation for you. Will not run any investigation?
Not in absence of any other features. If you find a mass or a cyst, then yes. So maybe she did, and Annie did very well by offering her a scan. Okay. If you see something there, then that's fine. If not, then no, not that kind of workup we don't do. Okay. Okay. So anything else by anyone?
Hello, Sam. Good evening. Vishnu Priya here.
Hi, Vishnu. Hello. How are you?
I joined late.
No worries. So you don't quickly say that what was what Annie covered and what. So I love this stuff. I'm most of the station went excellent actually, and you did very well. Okay, introduction, agenda setting, all fabulous. There's nothing that we can do better in that. I feel okay. So don't worry too much about everyone has their own style. If you are able to, if your style is slightly different from one person, doesn't mean that you are lesser than the other person. It just means that if you are comfortable and fluent with your style, just that should be fine. You should keep it up. Now, introduction agenda, I really enjoyed. You offered counseling right in the start. That was marvelous, excellent. So you nailed it there, because that's she has come with a concern and you are offering this. I think a huge chunk of your station gets addressed there. Very good communication skills. It gets counted as good communication skills, and you involved your colleagues as well in when you are referring to counselors. That was good. You could slightly have asked, do you know any risk factors of your friend? I know she would not know the history, and she would say, no, I'm not aware. It's just like trying to see that, trying to compare her risks with her friend's risks. Okay, so sometimes, we don't know. She may say, my friend was like very obese, or maybe, yes, her mother also died with some cancer or something like that. So she could say something. You can say always that you may not know a lot about your friend, but are you aware of anything like, did she have any family history of cancers or things like that? So you could slightly touch upon her friend, you did very well by saying everyone is different. In that sentence, you could add, you know, are you aware whether she's so what do you think, Annie? Is it like you think it's you good, or you think that you probably are better off without that?
No, that's fine. Like probably asking the risk factor would have been better, but
She would
like,
most
but
likely
I think,
say that she
yeah.
doesn't know, isn't it? But yeah, slightly touch upon. Are you aware of any risk factors in her? Like, was she too big? Or did she have a family history or previous history of cancers? Good, yeah. And you asked about the pills. That was, you know, these are like the most crucial questions asking right in the start. It scores you marks, it scores you ticks, and I don't mind any sequence problems at all, absolutely. Nobody has said that why Annie didn't ask about her fertility aspirations. Is it not a big miss, family, when we end up in this in the exam, or somebody knows that, oh, I know this station, she doesn't want
Yeah,
to.
scenarios can
that
be
you don't ask?
can be changed. Yeah,
No,
yeah, you're-
even if they don't change, this is what I want you to remember, all of you, please. Even if the scenarios are not changing even one fraction of a, you know, milligram or microgram or picogram, even if they're not changing, if you're not asking the question, then you are not actually fulfilling the demands of the scenario that you will do. Okay, even if they don't change the scenario, you have to ask. How would they know that you know you have to ask?
yes.
Okay, so even if ditto station comes, you always say, you know, because you later on you will be telling her pros and cons, and you know, why she should or why she shouldn't have oophorectomy, then this will help. Okay, that's an important one. I think that's one of the only couple of things that Annie missed. Annie didn't miss a lot. Okay, so that was good. And I don't think if we miss 1 point or 2 points, this a lot, it makes a lot of difference to our scores. Okay, you asked about the obstetric history. So I was thinking, when you asked about the obstetric history, you will ask, are you planning any more children? So you missed that. Medical history, you asked. Surgical history, you asked. Smears, you asked. We don't really apologize for asking STIs, okay? But it's no harm in asking, as if you wanted to say, you know. But we also don't use the word drugs for fun. That's something only available on Telegram. It's not in the hospitals. We just say recreational drugs. Drug for fun is a bit of belittling for the patient. Okay, so we'll say recreational drugs. That's better. Okay, so that's only that. Again, I don't think they will penalize you for that. It's just that if too many of these things accumulate, then the patient could, role player could say, okay, rather than a 2, I'm going to give a 1. If too many of these things accumulate, you haven't accumulated lots of these things, so that should be fine. RCOG says that you don't. RCOG says that the summing up of you know, the story with the patient that you do, that's for yourself. It doesn't score you any more marks. Okay, so if you think you have time, go ahead, do it. If you think you're struggling with time, then we don't benefit from it. If you think that you will want to make sure that you've missed something or you haven't missed something, then be my guest and summarize. Okay, because you know, did you see that your history part finished at 6 minutes? Who noted that? Anybody noted history finished at 6?
Yes.
Yeah. So yeah. So Annie, do you feel comfortable not asking? Just I'm asking you, or anyone else. Do you feel comfortable not summing it up if you know, if you think you've asked, or do you think that you might have missed a big thing? So it's safer to ask. If that's the way, then yes. If it's safer to ask, then fine. But then you need to speed up a little bit there. 6 minutes going in the history part is a lot. Okay. So risks in the removal, you told about, yeah. So first of all, you started with the risk of removal of the ovaries, and risk of removal, you first said technical points like, you had 3 sections, may not be able to complete, and detrimental effects on both bone health. I will encourage all of you to use heart health and bone health word. Okay, heart health, when you say, I know you talked about blood vessels, but if you say heart health, it has a very big, it has a bigger impact. Okay, heart, you are talking about heart, everyone knows that, my heart should be very healthy. So blood vessels, it naturally doesn't have that kind of impact. Okay, but you knew what you were talking about. Just I'm encouraging that saying heart health and bone health will be more impressive, and she will try to be convinced sooner if she hears about that.
Will decrease the sex drive.
Your sex drive will decrease if you are too dry.
Yeah.
So that's absolutely acceptable.
Okay.
Okay. I was becoming too much technical in that. Okay. Yeah. Noreen, I admit, it's a good one. Okay. Sex drive, because of course, if you're feeling uncomfortable or, it's a painful intercourse, your sex drive will reduce. Okay. So that was good. And then what next? You talked about the symptoms of menopause, mood, and all that. Now, yeah, my own low risk was because I was a Paris person. Okay, I was a Paris woman, so that would be reducing my risk. Yeah, agree? Parity will reduce my risk. COCP use will reduce my risk. Okay. Any previous, no, my current BMI is a healthy BMI. Okay, I'm not obese. So that will reduce, that is a kind of a protective factor. Okay, so what else? Were there any other? So I don't have a family history of any cancers. Okay, so that's again, it works in favor of, kind of the scenario. For me to keep my ovaries. Okay, so what we are trying to say here is that you are telling me that these are your protective factors. So I'll encourage you to feel safer. We don't know what the factors in your friends were, as you said in the start anyway, and these are you have these factors. You don't have a family history. We could have checked you for some genetic susceptibility like BRCA1 genes, but Annie, you know actually better than others that there are criteria for BRCA1, and she does not qualify for those, as per those criteria to have BRCA1 or 2 done. Okay, so that was. I don't know if they'll deduct on applied. I think they can bring the 2 to 1 on applied in, because this is a big piece of cake. Otherwise, they could start doing in everyone, and we don't want that kind of load on the NHS. So we'll encourage her that you do not, you do not have the risks that are the criteria for BRCA1 or 2 testing. And if she insists, then we can say that we can arrange a meeting with a genetist who can explain this better to you. So that can come, genetists can come in that respect, in that way. Okay. Then we are saying that, yes, if as Annie was continuing to negotiate with me, and if it comes to that I'm not being convinced after even she told me about heart and bone and all that, then yeah, she can offer me, she already said that she didn't ask the symptoms of, related to an ovarian mass or something. So she could say that next time we can have, you in the clinic and for a face-to-face appointment, so we can examine you, like your tummy and from down below, to see if I'm able to feel any mass, or we can book you a scan. That was good. If the negotiation is going on and I'm not satisfied, then offering a scan is fine. All the tumor markers and everything that will be coming after we find a mass there. We just don't do it blindly. Otherwise, that can become non-productive. Okay. So this is how we are stopping here. No other concerns. I'm happy with the station. I think definitely if we said we're not talking about passing or failing, so we can forget about saying passing or failing, but in my point of view, this is a good pass. I don't have concerns about this station. Okay, so just telling you things so that you're to organize your thoughts and to make you aware of the time management right from the start. Time management is very important. No? If you are not good with time management, then that would be an issue. Okay, so let's start with some technical things that we wanted to talk about.
Excuse me, Dr. Sam. As she told that CA 125 and ultrasonography, so can you explain to her about that?
I will not talk about CA 125 unless I have some reason to suspect, but they will not deduct your marks if the patient was not, my feeling is, my perception is that if the patient is not being convinced, and she said, then I don't think there will be a huge reason to deduct any score there, okay? I feel that if I was doing it, I won't say, okay, I'll try to talk her out of this by informing her and giving her time to think. I'll say that this is the written information. I can book you another appointment in 2 weeks or 3 weeks time. If I think that the negotiation is going towards a kind of a failed negotiation or complicated negotiation, I can always add the word that your next appointment can be with my consultant. You can come, and it would be a good idea to bring her back to the consultant. So because she would have read and then she would have made up her mind, maybe she says that, I still want it, then at least a consultant would be involved. So offering the scan would be still a good idea. Yes, as I said, somebody can feel comfortable of offering CA 125. I would probably have thought that if it's required based on, some ultrasound findings, then I'll request. Okay.
Okay, thank you.
Yeah. Please remember one thing, that it's not about very hard and fast rules. Okay. It's about your approach and your ability to justify things. That counts a lot in the OSCEs. Sometimes they're not rigid, fixed rules there. It's just about how you are able to comfortably convince inform that. It's not about really convince is also not a correct word. It's about informing the patient, giving her an informed choice, okay, and making her feel that you are listening and you are trying to help. All right. So let's jump to we won't do the second station now. We can probably do it in a minute. So again, I'll ask you the question. Do we know who is trying to book the May exam? How many candidates do we have? Girls? Anyone else for the May exam other than Salma and Annie? Okay, so, okay. Are we online or are we offline now? Because I don't hear anybody.
Yes, we are online. I just want to know about Sam that because the role player asking a lot of questions and she's talking too much, and definitely we have to give space to her. So is it important to wrap up to complete the station or to give time to the role player? I don't know if you can just put, because it will be helpful for the others also.
Absolutely. I'm first of all trying to see whether the others are online, or is it only their devices online, because I don't hear anything from them. And I would like to know if we are accompanied. So why are people so quiet? Hello, girls, come on.
Sam, we are listening to you. We are taking advices.
Come on, girls. When I'm trying to interact, then you should not make me feel that I'm on my own here. Yeah. Okay. With you, ma'am. Okay. Okay. So okay, I'll go back to Noreen's question. Should we try to finish the station, or should we try to listen to the patient? What do you think you should do? What do you think? What's natural?
Are you asking me?
Listening to the patient is more important and addressing her concerns.
Absolutely spot on, Annie. Absolutely. See, the patient will take you towards the end. It's the problem is when you think that patient has got some agenda not to take you to the end of the station. Problem is when you think that the patient doesn't want you to finish the station. Actually, she is the one who is going to lead you to the right direction. So people who think that, oh, I am trying to finish my station and this patient is just not shutting up, okay, they are doing a big mistake, okay? You see what I'm saying? You have to focus on all the cues that she gives and answer all her concerns. That's your station. If you are fixed on your template, then see you in the next exam as well, okay? So please don't do that, okay? Don't do that. Patient is your, light on that path, okay? She'll take you by giving you cues, by asking you questions, and you will be addressing those concerns. You are not going to get your mind fixed to your template and keep rushing that I have to finish this template, okay? That way, why do you think, guys, that people fail this exam so many times? Why do people keep failing these exams?
This is the main reason.
Absolutely, absolutely, Salma. This is the reason. People are going in there with the agendas that they are being told by, ABC and XYZ kind of people. They have got those templates fixed in their heads. They're going in, they've got their agenda that I have to say all this, I have to say all this, I have to say all this. And when the patient is trying to give cues, when the patient is trying to, take you in a direction, and you are thinking in your head that, what an ass this patient is, that she's not letting me complete my station. And she's thinking, oh, what a bum you are. Sorry, I enjoy talking like that sometimes, because this is the truth, that she's thinking, what's on her mind? What's the problem? Why is she not getting the hints that I'm giving to her? Okay. So please remember, she's there to help you pass the exam. Yeah. Okay.
Yeah, just I wanted to address this thing because I know my friends who are there, who finished the station in 9 minutes, and they spoke everything related to that, and they were quite happy that they will pass.
I'm not saying your friends will fail. I'm saying people who think that they have finished because they had that big 2-3 pages of rote learning and they were able to vomit that out there, and they think that they will pass. Many of our very brilliant friends keep failing because they are flooded with all that knowledge and they just can't contain it. And that's not the point of this exam. Okay, the point of this exam is you go talk to the patient. How are you interacting with the patient? Are you respectful, listening and caring as a doctor? If you're just there reading a book in your head and going up, then thank you very much, they don't need you. Okay, so that's the fact of this exam. Okay, they need a competent, caring person who can listen to the patient and address her concerns. Not bothered about, I have this agenda, I have fixed it in my head, what the crap is happening, that this patient is just talking and not letting me complete, okay, my station. So if people have this attitude, then they unfortunately fail. Then they find scapegoats and reasons saying, oh, this happened, that's why I failed, and this happened, that's why I failed. No, people fail because they are not able to prove there that I am a safe doctor, I give importance to the patient, and I listen to the patient, I respect her autonomy, I offer the options to the patient. I don't impose the options on the patient, okay? Always offer, not impose, you see? Agree?
Yes.
Yes, say yes, yeah, okay, thanks. So yeah, please say yes, that would be good. Even if you want to say no, that would be good, but say something, okay? So yes, please, that's the reason. I would want you, all of you, whoever is going to sit May exam or November exam, please first give yourself like 1 hour of thought in the start, think everything, collect all data that's available. And when I say data, I mean how many people fail, how many times they fail, have you failed at all, and what could be the reasons, okay? Because addressing those reasons is very important, because if we shy away from our mistakes, if we don't want to, if we want to just dump it on something happening somewhere in planet Mars and that affected your past result, then that means that you are not going to improve your results as well, okay? You have to focus on trying to understand what happened, why you failed, if you failed, and you need to remedy those weaknesses. There's a lot going on in the groups. There are lots of misguidances. When I started saying a lot that, please don't apologize for history of smoking, don't apologize for history of alcohol intake. People then in the various groups, they changed their strategies as well. Before that, I've got a record of their feedback saying to the candidates, sign post before asking smoking, sign post before asking alcohol history. When I tried to make noise, people did correct. And I'm even happy that even after me making noise about this, people corrected that thing, okay? But there's still so many other things that are sitting there, and people are very protective about those. I would just want you to please respect yourself, respect your exam. Please choose carefully who you are following. Please see whether your mentor is competent enough. What's their score? What did they score? What's their, so don't get impressed by if a person is teaching 400 people or 200 people and 10 out of them get 90% marks. That doesn't mean that it's because of them, because out of 400 there will be few bright people as well. So don't get misguided by these things. Please be very, very careful. It's your future. It's business for people who are teaching. Even I'm not excluded. For us, it won't have those drastic consequences like it can have for the candidate, who poor person is spending all the time, family time and money that could have helped the family achieving few other goals. Is so much sacrifice, and then ending up with wrong guidance, bad guidance, and ending up with failing. So please, this should be everyone's task. Go and see who, very carefully. You can prepare on your own as well. My exam, I never got any course, anybody's, I was nobody's student. I didn't have any mentor. I never posted any audio in the telegrams or anywhere, okay? And the only course that I did was RCO. I paid 200 pounds to RCOG for their course. So that's it really, okay? So people can do on their own as well. If you think because you're not UK based, that could be a problem, then fine, but choose people carefully, okay? Let me show you a slide I made on the basis of what one of my teachers used to say. So let me see if I can show it to you. So he used to use a bit of a harsher word. I've tried to convert it to a less harsh word, okay? So are you able to see this slide now?
Yes.
Yeah. So he used to say donkey, but I've changed it to a cart light. Okay. So he used to say, follow the starlight and reach the stars, follow a donkey and reach a barn. Okay. What's a barn? Barn is where the animals are kept. Yeah. So like, if you are following a light which is hanging on the back of a cart, or if you're following a donkey, this is what he used to say. So I thought I should be polite. So, but this is what you have to choose very carefully. Please, you can prepare on your own as well. Okay. I must encourage you, all of you, you can prepare on your own. And if you think you really need guidance, because it's not, you don't know UK-based system and all that, then you have to be very careful to find somebody who can help you rather than following the crowd. Okay. Don't get impressed by a few people who pass, because out of hundreds, few can pass. That's not an issue at all. That doesn't have to be us doing that magic. Okay. Or any mentors doing that magic. Now, quickly, I will talk about a few more things. Anyone who is new will benefit. I'll quickly try to go through those points. And if somebody thinks that I should expand on them, then I'll expand. Otherwise, I'll just assume that you already know these things. Okay. So let me enlarge this. Okay. We all know that this assessment of MRCOG OSCE is ST5 level. Yeah, anyone disagreeing or doesn't know what that means, please stop me. Otherwise, I won't waste lots of time on this. Okay. All what they're trying to do is they're trying to. So anyone who wants it, don't text. Okay, just speak. Say that you want me to expand on something. Okay. So. Okay, so okay. So, okay, sorry, I'm letting people in as well. Okay, so ST5 level, what they're trying to see, safe, competent, you know your limits, you are a safe doctor, you have the competence, you know your limits, you know when to ask for help. Knowing limits mean that you're not treating people when you can't treat people, you're not managing conditions when you actually don't know very well about them. So you knowing your limits means calling for help, calling for advice, seeking advice. Even we sometimes ask juniors for, sometimes we don't remember a dosage of a drug. That means that we know our limits. So even if a junior colleague is there, we say, oh, do you remember the dose of that? And that means that you are safe in that terms, you know your limits. Okay. And you are a good communicator, you communicate well with the colleagues as well as with the patients. You know when there is an emergency, how to lead, and you know when you are not able to lead because of whatever problem or less competence in that particular, something that you maybe not have done yet, not signed off yet, then or you something too complicated, then you are a good follower as well. You ask for advice from your consultants and multidisciplinary colleagues and all that. Okay, and you understand and respect patient autonomy. Okay, which means that you are offering them help, you are offering them choices, you're not imposing anything on anyone. Okay, so this is the aim, that this is what they are trying to assess you on. There are 5 domains, all of us know: patient safety, information gathering, applied knowledge, communication with colleagues, and communication with patients. Okay, so I'm again not expanding, not wasting a lot of time on that. You already know that. Okay, now shall we do another station quickly and then we talk about rest of the things, or shall we just continue talking about few more things and then we can come back to the station? Okay, let's continue with few technical things and then we'll come back to the stations. Okay, so you have to, as I said, you have to please see number of attempts, that how many attempts people are making before passing, and or if you have made any attempts before, please remember that. How many courses people are attending or you have attended, and then wisely prepare. It's not the quality that matters. Okay, it's the it's not the quantity that matters, it's the quality that matters. Okay, so suppose you are doing 10 stations a day and you are getting a rubbish feedback, that doesn't help at all. You think that you are achieving something. I'm sorry, you're not. Okay, you have to be very sure that whatever way you are preparing is helping you. towards your goal of passing this exam. Anybody thinks that doing more cases is going to help only without any quality of and more stations without any quality of those stations or quality of the feedback? Does anybody think like that? Please voice up your comments here. What do you say, Salma? Doing more stations is more important or quality of feedback is more important?
Yeah, I think quality of,
So if you did 10 stations,
yeah,
yeah, and nobody was able to pick up what your weaknesses were, then what's the point in that, doing those 10 stations? Yeah.
yeah.
You are just thinking that, oh, I'm throwing 1 station, 2 station, 3 station, 4 station, 5 stations. You're thinking but then I'm sorry, you are making a fool out of yourself. Okay.
Mm-hmm.
You are only making a fool out of yourself if you are. So again, I say, always please try to see what is the quality of feedback. How would you find out that? I mean, you are all doctors, all intelligent people, A-type personalities. Okay. So I think you should be able to figure that out. Okay. Like, for instance, I would see what's the competence of the person whom I'm asking for help. If I don't feel comfortable with that competence, then I will not ask, because it's not, my purpose is not to do 1 station, 2 station, 3 station, 4 station, and not even having a trust that this is a really high caliber feedback or high caliber input that I'm getting. Then sorry, you are wasting your time, your money, your family's money, your family's valuable time that they could have spent with you. Okay, so this is just a reminder, and I previously didn't think that I should give this to you, but then I thought that people who are preparing for exam, probably they are too stressed, and probably there's not, no harm in saying these things. So please don't just follow anyone. Don't harm you have a higher self-respect, you have a high worth, okay, and you deserve that you pay attention to what you're doing. Okay, so let's go to so as I said, this is short-sightedness, that if you so first I was thinking that I'll say that what wrong guidance is being provided to you, but that one cannot say in one sitting. So I put it in red and I crossed it off, because that is something, a slow process. And I think the best thing is that be careful. You can probably study on your own rather than getting wrong advices. Okay. Okay. I've been asked many times, what should you do? What should you focus on? So do you know how, are you guys like doing lots of pills and talks, and what's your preparation plan? Do you all want to share with me? So girls?
I think going through the pills of the patients that you see in clinic, that is very important,
Okay.
just to make sure that you know the layman language and the terms to use in counseling.
Okay. And do you have enough time now, if you're preparing for May exam, to do talks?
Not to do talks and all, but it's mainly the patient information leaflet, because I think I learn best with the practice that I'm doing at work. So I try to collaborate at the same time.
Excellent, excellent. That practice at work when you are sitting in front of your patients in your clinical areas, that's the best time to prepare and best way to prepare, however you want to do it. For me personally, I laugh with my friends and with my students as well, that pills didn't help me at all, because I read 2 pills, okay, in history. I read 2 pills and then I threw them because I couldn't fall in love with them, and I got too much like layman language that I use in the clinics, I just use that. Sometimes, I could probably, I think the exam role players, they are more fussy about the layman language, and the actual patients are less fussy actually. So we have to be careful. You're right, Annie. But I somehow managed to do, and so there might be other people who would probably be able to do without pills, but especially people who are abroad, they would get help from, I think pills. So if you don't know what kind of language you need to, speak to the patient, or if you're not, if you haven't got UK experience, then yes, everybody keeps saying pills. I personally only read 2 pills. One was PID and one was GBS, and that's it. I couldn't read anymore. I was bored to death, and that's it really. But yes, TOGs, I agree, there isn't any time really. Please, if people who are appearing for May, they have to choose very carefully what they are doing. People who are appearing in November, I encourage them to read the latest TOGs, that's fine. Okay, you're not going to lose a lot if you don't know a lot of TOGs, as long as you know the major conditions like, fibroid in pregnancy and things like, the most important topics that we have only covered from TOGs. You can go back and top guidelines. Are you appearing?
Some summary of green top guidelines.
Okay. Are you appearing in May, Sadia?
Hopefully, if I get seat.
Inshallah. Okay. So summary of green top guidelines, executive summaries. Yes, absolutely.
Yes.
What else?
And other is guidelines of FSRH contraception guidelines.
Okay.
Because it is very important sexual reproductive health scenarios.
Yes. Yeah. Okay. So absolutely. So green top guidelines are the most important. Okay. Other ones would be some important nice guidelines. Okay. Some important nice guidelines. Then yes, some from you should have some broad knowledge of all the FSRH concepts. Okay. So if you have done and highlighted before, that would be helpful, because then you can quickly have a bird eye scanning view of the guidelines, major important things. You don't have time to read in depth for the first time now. You would have done it for the part 2. So you could have a quick scan of those. You should know the UK MEC pages, those tables. You should know those for most important conditions. I would worry more about UK MEC 4 and 3. And if we remember that, we'll know that rest of it is fine. Okay, so try to do those as well. BASH guidelines, you only need the most important ones, like you need to have a bird eye view of all, but then herpes is very important. Knowing what would you do in HIV is important. Syphilis came in exam, yeah. So BASH guidelines would be important, yeah. Other things other than the guidelines that you are going to do are some books. Please do some books at least, okay? Oxford, Lisa Doyle, this Hollingworth, okay, Tony Hollingworth. These kind of books, they are good books, okay? Sometimes I don't agree with few things that they have mentioned, but that doesn't mean that you should not do books, okay? So I find faults in all the books anyway. I'm never very comfortable with all the books, but that's okay. You find fault, if you can correlate with the guidelines, and you are right. If you found that guidance says something else, then guidance is to be preferred. Then you can correct your book. Okay.
Green top guideline, of course, we should know.
Yes. Because if you know the guideline, you can handle the situation, because you know that where am I going, what am I telling the patient, and what are the answers to what she's asking, isn't it?
Yeah. Yes, absolutely right.
So that's green top is my love. Yeah, it's my love affair, green top, and then nice. Okay. So then as much you can add is good, more the merrier. Okay. So other than that, if you have, yes, RCOG course, when I attended, they said that, last 2 years TOGs. And the poor thing was that I was doing TOGs when I was preparing, like, more regularly. I mean, I was doing more regularly when I was preparing for my part 2. Now we passed part 2 in February 2020. And then COVID struck. And then all these almost 2 years, we didn't do any that kind of, theoretical reading or studies. Yeah. So when they said last 2 years talks, I was like, oh God, okay, we don't have that luxury. So I had to ask myself, am I doing talks or am I not doing talks? And I decided I'm not. Okay. Because I didn't have that kind of time. I only had 6 weeks to prepare and I didn't have any study leave as well. So that's why I planned it like this. But it went very well without talks. Okay. I didn't suffer even one fraction because of not doing talks. Okay. I only did ureteric injury talks, ureteric injuries talk, and fibroids in pregnancy, and a couple more I think I would have done. Okay. So what I'm trying to say is that make your own lists, don't follow my list, make your own list, what you think you will benefit from, and then don't get carried away that I want to read this new thing and this read new thing, and this information gathering has got it's just 20% of your full exam, and you will be fine with most of the information gathering. No, sorry, when I say information, I meant applied knowledge. Applied knowledge is only 20%, like all the domains are 20% of the exam. Now, if you think about applied knowledge, you will have most knowledge anyway. Okay. So new knowledge that you require, that won't affect lots of your marks. It will be like very few percentages where you should have known and you didn't know and you lost few ticks only. Okay. So I won't go for the new things at all. Target for your exam when you entered the station, first 2 minutes, tell me how you utilize those 2 minutes.
Yeah, I introduced myself, confirming
first
her
2 minutes when you were reading the question.
scenario. Oh, okay.
Did you open the station in front of you at any point, like during the exam?
Yeah. First station, that was the pre-op gynae, I couldn't open it because it was on the left side, just below my camera. There was the word document was there. So I need to click that. I was searching on the right side and I couldn't find it. Then the chapter.
Noreen,
Yeah.
did you watch my video on that?
Well, I did, but actually, honestly, I was having only 2 to 3 weeks to prepare myself because I'm working in a busy hospital.
That was highlighted
So I was
so much repeatedly in my video, that where will you find that station to open?
Yeah.
So you were later able to open the stations, yeah?
Yeah. Thank God I couldn't. I completed, although by any means.
I'm just asking about the technical bits rather than talking about what was in there. I'm asking about the technical bits. How you
only
handled.
I was writing the name of the patient and very few things. Otherwise, it was like, as you told, that keep in your mind bubbles. So I'm also keeping like this the chunks. Yeah, because from the beginning, because we don't know. We don't know what will be the scenario. Maybe, as you told, that it can be the repeat station, but it will be different from the previous one. So we have no idea that how it will go. So that's why just chunks should be in your mind, and that chunks you can manage with
Absolutely. Chunks, clusters of information. You can organize them in your head, like, there are bubbles, different bubbles. And this bubble methodology, this is much more better than a line by line written template, because that kind of is more confusing, while the bubbles can direct your attention. And that's why I keep teaching about bubbles, like mind maps. Okay. So that was good. Okay, great. Any questions, girls, from around the issue of starting your exam?
Sam, can we write the informations like the name or some important information, because these are not allowed in the online examination?
You cannot write. She didn't mean that she wrote on a paper. She wrote on, she entered, like typed on the clipboard that was provided there. Okay, so you're not allowed to write. Please.
But usually we don't have time to write a lot of things. Better to think what they have asked. Concentrate on that.
I didn't type anything. I absolutely
only name I was writing.
No, I didn't even click that box where we are supposed to. I didn't even click that box. Okay.
Okay. I don't know what will happen, Sam. I'm so scared because the exam was really quite easy. And couldn't I think I missed because giving the space to the role player, then you are able to miss a lot of things. I don't know.
This is something that needs a long discussion and all that, and lots of practice. So I would say that this is not able to cover this point here. All I say is that practice with somebody good, and you should be able to. I mean, my students didn't say anything like that. I was happy that they were happy. They're responding to patients' role players' cues. Then it should be not a problem, but that means you practice with somebody who who is able to give you feedback and train you in all these as you go. So I listen to the patient. Thank you. How to know his competence? Yeah. So Ishrat is asking how to know the competence of the mentor. Well, you ask them what's your score in the exam. You ask them when you appeared in the exam. Why have you appeared in recent years when there was this system, because previous exam pattern may have changed and all that. So these are the questions that you probably can ask. And I think that's it really. Good that you're not writing. Thank you. Thank you.
Yeah.
Because I prefer that you speak up, because that's
Thank you. So my question is, what is your opinion that, some are they like to, ask whole history, like, do you have any reservation for blood transfusion for every station, and also the recreational drug, and also that, do you have any objection for blood transfusion?
excellent.
So what is your, yeah,
you
please.
have an excellent point. You
And
want to know?
today case also, she asked the recreational drug. So do you think in this case also recreational drug is more important, or we can escape?
You could escape in this one. Okay.
Yeah.
So sometimes
thank
what happens is, so first of all, RCOG, I just told you guys that I spent only 200 pounds on a course, and that was RCOG. Okay. So RCOG examiner, senior examiner said that please only take targeted history. Only take targeted history. Don't go into detailed history for everyone, because that that eats up all the time that you have in hand. Okay.
Yeah.
So
Yes.
and it also, what's the problem with detailed history versus a targeted history? Why is it discouraged, detailed history? Because detailed history, we teach medical students to take detailed history, because with the passage of time, they'll become experienced and experts in taking succinct history, well directed, as per patient's concerns and complaints, and to leading towards a differential diagnosis slowly, or as they get trained. Reaching ST5 in another 2 years will become a consultant. So this is like ST5 is an evolving consultant, and they want to see you as a person who can take a targeted history, quick targeted history, no, rambling here and there, no, wastage of time. You have only 10 minutes, and you have to complete, you have to address her concerns in those. I'm not saying you have to complete your template that you have it fixed in your head in 10 minutes. It's not about you, it's about her. So you have to address her concerns in 10 minutes. Okay, so targeted history. Salma, thank you so much. That's a very valid question and very useful question. Targeted history, you can miss. So blood transfusion. Sorry, asking about reservation to blood transfusion. I'll ask only in a patient. Okay, obstetric patient, I'll probably ask as many as I can, not maybe several obstetric, I will miss that, okay, deliberately. But if a patient is hemodynamically unstable, or, has a diagnosis of ectopic pregnancy, at the moment she's stable, but, with ectopic pregnancy, she can anytime end up in an unstable condition. So in those kind of patients where I'm thinking that she may need theater today or in few days, I will ask, okay, reservation to blood transfusion. I don't ask blood group. That's a waste question. Why are you asking blood group? Reservation is the thing that you want to ask, and that's fine. I'll ask blood group only in a patient who I think I would want to rule out rhesus incompatibility, and that's it. I don't ask blood group in any other patient at all. Okay, maybe stillbirth or
Like miscarriage, maybe she need NTT.
yeah, absolutely. Where I'm wanting to, think about rhesus incompatibility,
Yeah.
then yes, I will, as I said. Otherwise, no. In a gynae patient or in any other patient, I'm not going to ask. And anyway, even if you are worried about whether, you will need to give NTD, you remember that you will be testing. Our patients don't know their blood groups, okay?
Yeah.
I don't know whether you know this. It's not like back home. It's not like India, Pakistan, where people know their blood groups because they are asked to bring their donors. Okay, here patients don't bring their donors, so they don't know their blood group. Most 99% of the patients don't know their blood groups. Okay, so those will know who would have donated blood or who were maybe rhesus negative and they had to have an injection or something. They would know. Most of the patients will not know their blood group. So it's a waste of time, really, and an unnecessary question. Then recreational drugs as well. This is not the situation, then don't ask. That's not smoking history. Yes, you can ask because it can be related to risk of cancers. Okay.
Yeah.
You can skip
But
drugs.
like that operative case, like maybe that any patient like placenta previa or anything that I'll do the cesarean section for cesarean section. So at the time I don't need to ask about the smoking, that she will go for the planned cesarean section or now emergency cesarean section. At the time I don't need to ask about the smoking.
Yeah,
alcohol.
no, you don't need to.
Yeah,
absolutely. If you are just if the situation says that this is an emergency patient who will, you are kind of consenting for theater, for elective section, or
yeah.
for emergency section, that's not the time to ask about this smoking. Yes, if you are doing a VTE risk assessment,
Yeah.
For
Yes.
that, if it hasn't been done, okay, if you are not aware of the score, then you will, because you want to know whether you will prescribe her low molecular weight heparin or not. So wherever there is doubt that whether you would do it or you won't do it, then it's safer to do it, to ask. Okay, like if you know that her VT is, but if there's an emergency situation in there, you won't. Okay.
Yeah.
If there is a stillbirth who delivered and she is, you are going in to talk about the post-mortem of the baby, will you ask her about history of smoking and drugs and all that? If that is,
I don't think so, because we know already antenatally already taken history, already assessed that
absolutely, there will be lots of history will have been taken. Just read the question properly. Please read the question. If they're saying only talk about post-mortem, if she is not asking what happened, so what I will do, I will leave these questions out until the point when the patient says, what do you think happened, doctor? Why did my baby die? Then I'll say, okay, let me find out your risk factors. Okay, would it be okay if I asked you a few questions to see what risks you had? So, before that, we say that, of course, empathize and say that I'm so sorry this has happened and I know this is terrible and all that. After empathy, we will say that to answer your question, I know that in half of the cases we are never able to find what happened, but I can try to find out your risks. Is it okay if I ask you a few questions? And then you can ask those questions. So you don't have to waste your time because she may not ask those questions. So if she asks, then you can ask questions. Okay.
Yeah. Thank you.
Those people who think that the history has always to be done in the first half of the station, those people lose a lot of time. Okay. I just carry on with the station. I just get on with my job. And as the situation arises, I then ask questions. Okay. For instance, patient asks me something and I think that there is a relevant information that I need for that. I say, okay, to answer that, is it okay if I ask you another question or a few questions? And she says, yeah, sure. And then I say, okay, this, and then I, assess the information she gives me, and then I reply to her, okay, so this is what I think. So I always do this. Okay. So I don't waste my time. That's why the question that Noreen asked, it never happens to me. It never happens to me. I just go with the flow with the patient. It never happens that I have to decide whether I have to finish the station or I have to, go with the patient's flow, because I know patient's flow is the right flow. She is going to take me to my pass mark. So I never end up doing that. Okay.
Yeah, thank you.
Yeah. Any other questions, girls? It's your exam, girls, so please feel free, because it's not easy to find time, and I wanted to make sure that you girls, if anyone has any question, you are able to ask me. I'm here in UK. I'm here for the last like 20 years, and if I can give any input, I would be more than happy. Any questions at all, girls?
And another thing that, can I ask some, if nobody's
Sama.
asking, I can ask. Yeah.
No.
So like, anything, that option, when I'll give her available option for any case.
Yeah.
So do you think that first of all, I can tell this option, that expectant management, that means wait and see, and then medical management, surgical management.
Absolutely.
So then I can ask her, do you have any preference or anything? Then if she'll tell that, okay, I want surgical management only, I don't want. So do I may explain to other option, or I'll explain only the
Salma,
surgical?
I get
Can
your
I
point.
ask?
I
Yeah.
get your question. Okay.
Yeah.
So you don't go in thinking that this is what she will do. You go in thinking that I will give her, because she has to make an informed choice. Informed choice needs to be that you inform her of the options before she makes up her mind. Some patients say that I already know this option and I don't want that. That's a different situation. That doesn't apply to all the situations. You go in with the mind that I'll tell her. So first of all, you will enumerate the options. Like, I always say to my students, please step back and describe the forest. Step back means don't start talking about one tree. You go back and see there how many trees are there, how many options are there. So say, conservative, medical, surgical, and then you say that I can explain these to you. If she abruptly says that, doctor, I don't want surgical, then you can say, okay, I respect your wishes. I will tell you about medical and conservative, but also please remember, if in her case surgical is, a reasonable option, then do say that I would also want to inform you that although you don't want surgery, there might be, whatever. Like for instance, I tell you, if a patient has got a beta HCG of, nearing 4,000. So some people I see that they just say that, okay, you don't need surgery, fine. I'll talk about medicine and I'll talk about conservative option. But I personally would always want to say that that's absolutely fine. I'll inform you about conservative management and medical management. When I finish with that, I'll say, I want to inform you that although you are okay to go ahead with it, medical management is still fine, is an option for you, but the surgical, sorry, I'm getting distracted by somebody's text message that appearing on the screen. I'll get back to your message later. Let me finish. So yes, when I'm saying, and the patient has already told me that she doesn't want surgery, what I will do, I'll say that I have to, I need to inform you that you are still at a higher risk of having a ruptured ectopic, because if anything between 1.5 thousand to 5,000, we do say that medical and surgical both options are suitable for them, but we do say that increasing values of HCG means that risk of rupture increases significantly. If we are not informing them and say, oh yeah, you're fine, you can have medical, go on, go, I'm done with my station. So that will mean that you have not addressed a patient safety issue there. Okay. Yeah. Always say that I respect your choice, but is it okay if I informed you that there will be a higher risk of rupture? Okay, and you may end up with an emergency procedure anyway then, okay, to save your life.
Yeah, thank you.
And you medical, but
right.
This can happen. Okay.
Right.
So please keep in your mind that she has to make informed choice always.
Informed choice, yeah. So if it is written in the question, like, like stress urinary incontinence, written that patient wants only surgical management. At the time, do you think I'll explain the other option also, the lifestyle modification and medical?
Sorry,
if it is-
Salma, just if you can give a pause for a second. Let me see, somebody was
Sure.
requesting something.
Okay,
Who
sorry.
was requesting a link? Who was it? So I think it was Pranaya. Puja. So is hi Puja. So is it your where is the chat from? Okay. 3 new messages. Okay, hi Puja. So if your friend is a candidate, not a decision, could you repeat us how many months would be enough to prepare for the exam? I will tell you in a minute. And Pooja, is your friend a candidate, please?
Yes, ma'am.
Okay. Because I've only stopped the non-candidates to, from joining us. It's only for the candidates, not for the mentors and not for.
Yeah, but the candidate is trying to join, madam, but it's asking some password. She's telling like that.
Oh, is it? Okay.
Yeah.
So here we go. If you have a look at your message, okay.
She has messaged in a Telegram group also, madam.
She has messaged in Telegram group.
Yeah, your Telegram group, madam.
Okay, let me see.
Just, yeah.
Wasn't able to join. Is it Palak?
Pooja, madam. Pooja.
Pooja Arora, please add in.
Yeah, Pooja Arora.
Wait. Hi Pooja, I've shared the link. I don't know why is it not allowing you. Please try the link again. I'll post the link again here. Sorry about that, darling.
Okay, thank you, ma'am.
Okay, I've sent her the link again. I'm so sorry, girls, if there is some. Oh, Pooja, why is it? No, don't do that. Come on, send my picture there. Deleting that. Sorry, girls. Sorry. So I was trying to record a message for Pooja. Yeah, Pooja, the password that they will be asking will be your Gmail, because you will be logging using your Gmail. So it's the password for your Gmail that the Zoom will be asking you to join. I'm so sorry about that. This time the setting has been a bit of, I think, a nightmare. I just wanted to make sure that the spammers are not there. So try using the password of your Gmail, okay, for logging into Zoom. Sorry, girls. Okay. Anyone else has a message for me? Okay. Goodness gracious. Okay, sorry. I'm not happy with the settings this time, girls. I think lots of people are trying to join and they're not able to join. I apologize to all of them. Okay. So Pooja, did Pooja manage to get the link working or not, Prerna?
Yeah, ma'am. Just I will find out, ma'am.
Please see.
No, I will.
Otherwise,
call her.
yeah, say that probably have to do a sharing of the records. So anyway, girls, this was the reason. So you see, I don't I didn't do this session to introduce, to say, okay, this is my this course, this is my this course. I'm not selling my courses here. Anybody who wants the courses would directly contact me, and that's it. This session was not done to sell my courses. This is my May course, this is my November course, this is my circuits and all that. So I don't shy away from saying what is the fact. I'll just say it, and anybody who would want to get my help in terms of those courses will contact me directly. Don't expect me to talk here about my courses. Okay. So anything else, any other question that you have, please fire. Please tell me now.
Yes, that one what I asked you, that in the question, if it is written that patient wants that surgical management only for that stress urinary incontinence or other case.
So
So
see,
it is,
yeah, sometimes the patient gets referred by GP, okay? And they say that the patient wants hysterectomy for, PMS, yeah? What do you think you will do there? Will you just say that I'll only talk because the question already says that she wants surgery, or will you talk about other option?
I'll ask the patient also permission that she wants to know or not.
Yeah, I'll say, for instance, in this station, when this is, the GP has said that patient wants a hysterectomy for PMS, I'll say that I understand that you have requested removal of your womb for your, symptoms. She says yes, and I'll say that I'm so sorry to hear that this is so terribly affecting you. Are you aware that there are so many other options available before we, go to such a radical step?
Yes.
Do you want me to talk about those? And
Yeah.
you get her permission, and then you talk. Okay, this is what they're looking for. This is what they want to see. That can you do it?
Yeah.
Yeah.
Thank you.
Okay. Pooja is not able to join. Oh, poor girl.